Hello, dear friends. In the last three parts of this lecture, I demonstrate how to diagnose autonomic dysfunction with a 24 Holter ECG or an active standing test. In the third part, I explain how to improve physical performance by lowering heart rates, and now I try to demonstrate how we can improve our understanding of the pathophysiology of COVID-19 by using heart rate analysis and the evaluation of autoimmunity.
Analysis of heart rate variability is not really new. There are reports about Chinese doctors who use pulse diagnostic to predict the death of their patients. But today we have new technologies to analyze heart rate variability, for example, with such an 24-hour Holter ECG. Most of our studies based upon this technology. Moreover, today everybody has the opportunity to measure his own heart rate variability with a fitness tracker, and sometimes our patient will understand more than the doctors how to use it. Now to our case is the first published case of RFR analysis during acute COVID-19 disease. It's a 50-year-old pediatrician. He has SARS-CoV-2 PCR positive and antibody positives, and a disease between the 10th April and the 24th April 2020. The symptoms are medium with a loss of smell and taste, severe body pain, fatigue, fever, and cough. He is monitoring his stress level with the Samsung Health app. He monitored his heart rate with live track Zoom HRV, and he used a HRV monitor with the Pathfinder Holter ECG during the disease. Showing this slide illustrates the data of the Samsung Health app, and in the first early disease, the stress level seems to be very low. The same data are measured at late disease, and later, during recovery, he developed his normal stress level. This chart is showing the detailed HRV analysis with the Holter ECG system between the first day of the disease and the recovery at the 16th day of the disease. The mean heart rate seems to be unaffected, as well as the vagus activity indicated by the green area of the FAST-4 analysis. However, there is a decrease of global heart rate variability indicated by the SDNN value and the total power of the FAST-4 analysis. In the first publication, we can show that the patients have very low global heart rate variability indicated as total power, but he didn't show the increase of heart rate during COVID-19 that normally is related to heart rate variability. The patient had more than 15 Holter ECG during the last 15 years, and there is a clear relationship between the total power and the heart rate. If the heart rate is low, the heart rate variability is high, and if the heart rate is high, the heart rate variability is low. This relationship is broken during COVID-19, as published in this paper. We try to develop an algorithm to predict the complication in COVID-19, and we use a plot of the global heart rate variability, SDNN, and the difference of the heart rate at day and night. the heart rate difference, the circadian heart rate difference. These are all the heart rate disease from this patient at baseline with the heart rates and during COVID-19 in the quarters, although with very low heart rates compared to the other heart rate. We speculate that there is a critical window for COVID-19 complications that are not reached from this patient. If we use this algorithm in our data from our online monitoring on our intensive care unit, we see again that those patients who have a fatal outcome or a transplantation are within the critical window, and others who survive their disease are far away from this critical window of heart rate variability. Taken together, this algorithm has to be proved in a real-life setting in adults, but from our view, it is a promising tool to predict the risk for COVID-19 complication during the current pandemic. What happens with heart rate variability during long-term follow-up of our patient? He is wearing the life-track Zoom RFR more than 2 years, and we compare the data from 2018 with the data from 2020, and there is the RFR score show the decrease of heart rate variability the month after the COVID-19 disease. And then he recovered to normal values. The so-called multisystemic inflammatory syndrome in children is a post-infectious complication in children after COVID-19 that is a life-threatening disease with inflammation and heart problems and lung problems. This is one patient, an 8 years old patient who has this syndrome, and we see the very low heart rate variability in the intensive care unit monitoring, and after giving iv-Immunglobilins, the heart rate variability steep increase, and the kid is healthy again. The heart rate dropped down to normal values, and the boy can leave the intensive care unit. Multisystemic inflammatory syndrome is a special complication in infants. Most other patients who suffer from disease after COVID-19 have other symptoms like dizziness, fatigue, and low physical performance. Our understanding is very near of that of Starberg, recently published. He see sinus tachycardias and post-oral orthostatic stress syndrome in this patients, how I will demonstrate in the next cases. This is our first 16 years old girl with long COVID syndrome, and she had to stop the active standing test after 30 seconds, of course, his dizziness. She tried again, but it's nearly not possible to make an active standing test. After giving 10 milligram propranolol, she feel better, but at the standing test, she collapsed with a vasovagal syncope after 4 minutes. After the recovery, treated with supplementation of omega-3 fatty acids, she's completely normal in the active standing test and clinical healthy.
This 16-year-old girl developed a severe post-oral orthostatic tachycardia syndrome 2 weeks after BioNTech vaccination, and she goes to hospital, but the reason is not found. We analyzed her heart rate variability in 24-hour ECG and found this tachycardia in situations with physical activity. She stopped her physical activity, of course, this tachycardia, and in the afternoon she's completely laying down because of this phenomenon. After Ivabradine, the mean heart rate dropped down from 96 to 77, and she has no tachycardia while standing, or slight tachycardia while standing, and we found an improvement in physical activity, and she recovered from this complication. The Ivabradine therapy shows little effect on heart rate variability measured by the fast Fourier analysis while lying, but progressive improvement of heart rate variability while standing 6 weeks after starting Ivabradine therapy. This case of a 16-year-old girl shows an inappropriate sinus tachycardia 1 year after COVID-19. She suffered from a long COVID syndrome and have many hospital stays and ambulance visits, but she didn't recover. We diagnosed an inappropriate sinus tachycardia and treated with Ivabradine. She don't tolerate it, and now she's on low-dose Propranolol, and her heart rate decreased from 104 to 85 during 24 hours. She slightly improved, but she had further problems. The comparison between the baseline values and the Ivabradine and propranolol therapy shows a progressive decrease of the mean heart rate while lying, although a mean decrease a progressive decrease while standing in the active standing test. We have the highest heart rate variability measured as SDNN and RMSSD during propranolol therapy. It is difficult to understand the ongoing problem of the girl despite this highly significant improvement of heart rate variability, but we found many autoantibodies against thyroid peroxidase and anti-thyroid receptor autoantibodies, and further G-coupled autoantibodies against anti-muscarinic cholinergic receptors. And we speculate that this disease is the ongoing problem of the patient. This publication from Doltan clearly shows that SARS-CoV-2 is an instrumental trigger of autoimmunity with many autoimmune diseases. It seemed that COVID-19 induced a hyperstimulation of the immunologic system by molecular mimicry that is the reason for the autoimmune disease. A further paper published by Shang show that in the conclusion, we conclude that SARS-CoV-2 causes development of new onset IgG autoantibodies in a significant proportion of hospitalized COVID-19 patients and are positively correlated with immune response to SARS-CoV-2 proteins. Indeed, we found highly elevated G-coupled receptor autoantibody in all these diseases after COVID-19 who develop multisystemic inflammatory syndrome, long COVID syndrome, or in patients with problems after vaccination. I know these are very exciting preliminary results that have to be proved. However, we think we have to learn a lot about the autonomic nervous system and COVID-19. Moreover, it is possible to understand autoimmunity caused by the disease and the vaccination to overcome this pandemic. Thank you for your attention.